Thank you very much for this very kind words. It's always a pleasure for me as well to be in contact with you in real world or virtual world. I wish I had been in Cairo. And thank you very much for this very kind invitation. For the next 15 minutes, I am going to talk about EUS guided biliary approach in benign diseases. May I take slides, please? Yes. You go on with the slides. Benign biliary conditions requiring endosonography guided approach are biliary strictures, duct stones in patients with surgically altered anatomy. And previously, percutaneous approaches or double balloon endoscopy or surgery have been used for these patients. But every one of these approaches have their own drawbacks. Percutaneous approach has limited success, and double balloon endoscopy is a cumbersome technique, and it may fail in many of these conditions. And surgery is very costly as well as it is complicated. So we think that in benign biliary conditions, endosonography guided approach is a feasible option. The next slide, please. Previous slide, please. Previous one. The technique of biliary approach and sonographically guided biliary approach is somehow different from what is in malignant conditions. The approach is mostly from stomach. In case of total gastrectomy, we approach from jejunum. And in some cases, without surgically altered anatomy, we approach from duodenum. A large duct should be selected and stent should be deployed centrally and while the guide wire preferentially in duodenum. Because if our guide is in duodenum, we guarantee that further interventions will be successful. If we put the stent in a very peripheral bile duct, and if we cannot approach the central ducts, then we cannot do further procedures. In this procedure, we always use fully covered biliary stents, and then sometimes after therapy completed, we use double pigtail stents. So the specific hepaticogastrostomy stent that have an open part in distal 1/3 is not applicable to benign biliary conditions because ultimately we are going to remove the stent. The time allowed for the development of fistula is usually 3 to 4 weeks. So after putting the metallic stent, we return in 3 to 4 weeks and we perform our therapeutic procedures. And the maximal time it may be kept and safely removed is not known exactly, but we believe that it may be up to 6 months. So even after 6 months, it may be still possible to remove these stents, but usually we do not leave them for more than 4 weeks. The video now, please. The next. Yes, you can open the video. In this patient, you see we approach from the segment 3, and we prefer a large duct. We enter with 19 gauge needle. This is a patient with previous hepaticojejunostomy and gastric resection, partial gastric resection. And we feel the duct. And you see there is a very large stone. Actually, this patient has been tried to be managed with percutaneously previously, but it failed, and surgeons were reluctant to perform operation. So finally, this patient came to us. And you see there is actually no problem in hepaticojejunostomy site, so we can inject contrast into the duodenum. Then we put the fully covered metallic stent. This is 10 millimeter to 80 millimeter. And we leave the stent for 4 weeks. And we return. When we return, actually we did not remove the stent, and we fixed it to stomach with some clips in order to prevent migration while performing these therapeutic procedures. We insert an spyglass into the hepatic duct, and we perform laser lithotripsy. Actually, sometimes advancing the spyglass to the desired place may be difficult. So you can go from left to right ducts for some peripheral ducts. So sometimes it may be difficult. So you take your time and you try to reach your desired point. And for this very large stone, we perform laser lithotripsy. Nowadays, there is an electrohydraulic lithotripsy device from Boston Scientific Company as well. So instead of laser lithotripsy, electrohydraulic lithotripsy may be an option as well. And actually, this is not a very short procedure. Sometimes it may take up to half an hour to even 1 hour to disintegrate this. So then we insert a balloon, ERCP balloon, and we expel the disintegrated parts into the jejunum. So in ERCP, we retrieve here, we expel the disintegrated parts into the jejunum. And you see, we check the hepaticojejunostomy site. There is no stone anymore. This is the hepaticojejunostomy site. And now we are in jejunum. There is no obstruction. The procedure is complete. And after completing this, we can either remove the metallic stent and put a double pigtail stent and keep it for 6 months, and then we can remove everything. This is another patient. This time, there is no hepaticojejunostomy, but there is an stomach operation, and because of this, we cannot reach papilla artery. Again, we put a stent. Actually, for this patient, I guess because we did not have a fully covered stent, we put a partially covered stent. But actually, I do not advise this because even in 3 weeks, it may be difficult to retrieve this stent. And I think we used this because at the time we did not have a fully covered stent. It can be removed still until 4 weeks, but it may be a problem to remove. So I do not advise to use this kind of stents. We fill the common bile duct, and you see very, very large stones. But this time, there is no hepaticojejunostomy. Any problem? I think there is a problem with connection. Yes, you go on. Okay. And again, we insert spyglass. And as I said, it is sometimes difficult to insert spyglass because we are going a long way. Sometimes we go forward and back and we approach finally to the desired position. And we disintegrate the stones. And finally, complete disintegration, some remnants. We dilate the cholecystectomy part. Another patient, this time our target is gallbladder. This patient is not suitable for surgery, but there are very large stones and very frequent cholecystitis, and the patient is not fit for surgery. We puncture with 19 gauge needle gallbladder, and this time we put an lumen opposing stent from microtech, not a hot one. This is the stent. After opening this part, we pull the shaft and we open the proximal part blindly. Endoscopic view is not mandatory. This is the inner part. Pus is draining. This is the proximal part of lumen opposing stent. After 4 weeks, we remove this stent. We remove the stent and we go in with a gastroscope. This is the inside of gallbladder. Stones. We remove the stent simply with extraction basket. Sometimes we can also use laser lithotripsy for gallbladder as well. And this patient did well after this procedure. So in gallbladder stones not amenable for surgery, we can also use this approach. Can we go a bit forward? I cannot do it from here. These are the stones. You see, we are removing the stones with extraction. basket. Okay, can we go a little bit forward with the video? Yes, good. This time I am going to use cholecystectomy for benign problems. This patient presented with a common bile duct stone, but because of cholangitis, there was an stricture, and ERCP was not possible. And they tried it in other centers. I tried, I was not successful as well. And then I decided to put an cholecystectomy stent to let some time for the relief from cholangitis. This is the stent. And the patient actually did well for some 4 weeks. Fever subsided, leukocytosis and CRP elevation regressed, and then I returned, and this time ERCP was possible because the cholangitis regressed and stricture can now be overcome. And we performed ERCP, removed the stone, and this is the ERCP procedure. You see, this is a bit eccentric position. Actually, for hepatogastrostomy, after removing the stent, we do not do anything. But for this patient, after removing the stent, we put some clips. I don't think it is actually necessary. And I believe that if you leave it for 6 weeks, fistula will develop and closure is not necessary, even if you perform ERCP. And the last patient, there is a patient with sclerosing cholangitis, and you see this segment is very, very thin, stricture. Patients diagnosed with sclerosing cholangitis, and several attempts failed to drain the bile ducts, and there was severe hyperbilirubinemia. And in this patient, we also put an cholecystectomy stent. And after some time, we returned and we performed balloon dilation from this site, and we performed ERCP. In conclusion, Chairman and colleagues, in patients with benign biliary problems, endosonographic-guided approach is feasible and safe method. In the use of benign biliary conditions, long-term results are available, but to a limited extent in some core studies only. So I think in the future, with the compilation of the data from cohort studies, will shed light to this issue, and probably we are going to manage most of these patients with endosonographically guided approach. Thank you very much.